All right. Well, they set up the slides. My name is Luigi Notarangelo. I'm here at the NIAID. I was asked by Raffaella to give you a very brief overview in 3 different vignettes of what is the situation of transplant in autoinflammatory diseases. And the 3 disorders that I will briefly talk about are DADA2, XIAP deficiency, and POMP deficiency. And you will see in these 3 different situations where we are in terms of outcome of transplantation and where we're going. All right. Harry, you go first.
It's on. So I thought I'd go last just because, you know, the critical issue here is I was asked by Raffaella to do was to sort of introduce the concept of gene therapy for the disorders that are of interest to this group, and really there are only 3 major approaches these days, and most of these diseases, of course, are diseases involving immune cells and the hematopoietic system, even though target organs of damage can be skin and joints and brain and central nervous system and so on. So the one of the points I was going to make in the slides that that now are off the screen is that is that particularly if one is targeting the hematopoietic system, whether it be hematopoietic stem cells, and then giving rise to all the other cells, including particularly for some of the diseases here, monocytes and so on, or T regulatory cells and so on, is that there's really 2 things available for gene therapy. One are lentivectors, and a point that I was going to make, if my slides come back up, is that there's been a real sea change in what we can do with lentivectors. And so, whereas many of you may have sort of put aside the idea that you could use a lentivector to fix this because, you know, how can I regulate the gene? Because the lentivector goes into the hematopoietic cells and just produces the protein all the time. But I think there are newer ways of getting really tight regulation. Oh, you got Gigi slides. It's comical. Okay. So the what I was going to do is, one part of my slide was I was going to talk about the fact that there are now some papers out there in which people have been finding new ways to get to identify tight regulators and promoters, so that one can get very specific regulation using lentivectors. And the paper I was going to show, if my slides come up, is not one of mine, but a paper by Don Cohn's group recently in I think in May, in which his group had identified some really key regulatory elements for FOXP3, and in a mouse system was able to use that in mouse xenografts in the NSG mouse to very specifically correct IPEX because the expression was limited to the Treg cells. And all right, so now I can move. So what I'm going to do is, Gigi's right. This will work. I'm going to skip a bunch of stuff here, because otherwise we'll never get through. Okay. So one of the things I wanted to bring up that's very interesting is that a number of groups have demonstrated FOXP3 lentivector transduction of T cells, that they can turn effector cells into T regulatory cells of the same targeting specificity. And it really looks as if some of the T-regopathies out there, including some of the diseases of interest to you, may be able to be, that this may prove in the future to be an interesting gene therapy approach to treatment of those diseases. And then I wanted to just focus on I'm going in the wrong direction, so sorry. So then I wanted to talk about this paper, which actually was in Stem Cell in February, in which the Don Cohn's group showed that lentivector-mediated unregulated expression, if you put it in hematopoietic stem cells, would affect differentiation of cells. So of course, you can't just use a lentivector. You're going to have to make it tightly regulated. This is an area where people are talking about editing. And I'm not going to talk about a lot about editing right now because I'm supposed to give a lecture about it tomorrow. But I think what you're going to hear from me tomorrow is that there's an exciting future for gene editing. But when it comes to homologous recombination to put new genes into the disease gene, that would be the way to get tight regulation. In fact, we've still got a long way to go. There's a lot to do. But lentivectors are current. We can do things with lentivectors. And what they've done is, so they made this vector, and this slide, I'm not going to go through it except to say that once they transduced the stem cells with this vector that now is tightly regulated, you can see that everything is being expressed in the FOXP3 positive Tregs. And so there's a lot more to this paper, and I recommend you read it because I see this as the future of tightly regulated gene therapy using lentivectors. My lab works on both lentivectors and on gene editing, but it sort of made the best way of doing things win. The other thing I was going to talk about, if I can just move once more forward, is that there's a real game changer in the lentivector area, and that is that the discovery of synergistic combinations of lentivector transduction enhancers. And you can see there's a whole bunch of papers all this year. There's something in June of this year, and something in April of this year, something in January of this year, something in December of last year. And while many of these enhancers of transduction have been discovered over the last couple of years, people are now combining them in ways that are quite dramatically effective. And I'm going to just show you something that we're actually already using in the clinic, which is that this isn't the only combination that may work, but there's something called LentiBoost, which is a polyxamer. It's a long charged polymer. And if you combine that with modest doses of prostaglandin E2, I don't have a pointer here, but if you but is there a pointer of sorts?
This actually, the first one, the one on top, if you just hold it, that's what I work.
Okay. So you can see that if we've got a good vector, that when you transduce stem cells gives you about a copy number of 0.56, which in this case means about half of the cells have a vector in it. And then you come along and use the PGE2 alone, you get a lot more, but that same 20% of vector. But if you use this LentiBoost, you get synergy. But when you combine them together, you can get rather amazing copy numbers. So this doesn't mean that 300% of the cells are transduced. It means that cells have an average copy number of 3.73, and that we know it translates into somewhere around 80 or 90% of the cells are transduced and have at least one copy. and then a bunch have more copies. Now, you may not want a lot of that, but if you also combined it with tight regulation, that's really good. We're one of the few groups that's now brought this into the clinic, and I'm going to use this as the last slide, which basically says that if we were, when we treated our first 8 patients with XSKID with this lentivector, this is the product. And so you can see the percent of CD34 cells that contain at least one copy of vector without transduction enhancers. And there's a lot of variability and so on. But once you add these transduction enhancers, not only do you have really high numbers, but it's much more uniform. And this is a game changer. This is going to make things possible for a lot more rapidly and with more diseases with lentivectors. And I'm going to stop there because I don't want to take up the whole time. But I basically want to just say that my main point is that we should be thinking about gene therapy for more diseases than maybe you had been thinking about. And actually, my last slide, which I don't need to show, is that it is. Let me just keep going because I don't want to actually show my data. So one last thing I want you to think about. There's binary thinking. People tend to say either we use small molecules and biologics, or we try to use cell therapy. But in fact, many of the diseases that are talked about at this session are such that the biologics don't do the whole job, and probably the cell therapies won't get to all the organ systems, and that we should be thinking about combinational things a lot more in terms of planning out what might be best for our patients. And I'll stop talking and give the rest of the person time to speak. Thank you.
Okay, so can you now move to my slides? All right, good. So as I mentioned, I would briefly cover basically 3 scenarios where hematopoietic stem cell transplantation has been used in the clinical practice, and that's for DADA2, XIAP deficiency. These data have been published, so we'll briefly review that. And then we have here actually Cecilia Poli, who was one of the first ones to publish on POMP deficiency as a model of Candle disease, although there are some controversies whether POMP deficiency is truly a Candle disease. And she's been actually the one with a group at Baylor who has performed the first 2 transplants. This is still unpublished, and she may tell us more about that. So I don't have to tell you about DADA2, but obviously there are a number of clinical features in DADA2. And one of the things I want to emphasize is that some patients actually do present with significant immunodeficiency, often in the setting of common variable immune deficiency-like situation, hypogammaglobulinemia. The group in Freiburg has described many patients with this phenotype. Some patients actually present with serious infections. Next to me, actually Dennis Hickstein here at the NIAID has transplanted with Steve Holland a patient that they thought had actually GATA2 because the clinical features were more similar to a monomac syndrome with Mycobacterium avium complex and Fusarium infection, as well as monocyte problems. And in retrospect, that patient actually was found to have DADA2. So sometimes we transplant patients without knowing what the disease is, and we discover only afterwards. And so the phenotype of DADA2, of course, is very diverse. And by no means I'm going to tell you that a transplant is the mainstay of treatment, because in fact it's not. We all know that TNF blockade is the mainstay of treatment for this disease. But if you have patients with serious immunodeficiency or serious infections, use of TNF blockade may actually be detrimental and may not, in fact, at all correct those problems. So in those situations, transplant can be considered and should be considered if you don't have a good success with the canonical treatment. So what is the experience of transplantation in DADA2? There's a paper that actually summarized this experience. We're talking about a very limited number of patients. And the point I want to make here is that, as you can see, patients are heterogeneous in this study in terms of the type of donor, the type of conditioning that they got, and even age of transplantation. So this is a multi-center study. So it was a collection of patients treated at different centers. And as you can see here, the donor type, there was only one case where the donor was a haploidentical, and actually that's a patient from NIH. There are several match-unrelated donor transplants. The majority were match-unrelated donors. There were a few that were mismatched unrelated donor transplantation. So by far and large, actually, the majority of the patients were unrelated donor, which is not a bad idea for data 2 if you want to avoid the issue that was mentioned previously of transplanting from a sibling who may have the same disease and not being properly diagnosed at that time. The source was also variable. Some patients had received bone marrow, others received peripheral blood. And more importantly, the type of conditioning was different. So the majority of the patients received 5 out of 14 received reduced intensity conditioning. There were several that received myeloablating conditioning. And then you have here this acronym RTC, which stands for reduced toxicity conditioning. We tend no longer to use MAC and RIC. We talk about degree of toxicity of the conditioning regimen. But in this slide, RTC means to indicate that these patients receive triosulfan as opposed to busulfan-based regimens. And there is some suggestion actually triosulfan may be less toxic. As you can see, irrespective of the type of donor, of the source of the stem cells, as well as of the intensity of conditioning, all patients achieved very good chimerism. Whenever we go beyond 95% donor chimerism, we also talk about full donor chimerism. So in this series, actually all patients achieve full donor chimerism, which is something very important because in this disease, you may want to target the myeloid compartment if you really want to correct the disease, or at least most of the disease. So what was in fact the situation in terms of correction of the disease phenotype? So here you have again the same patients from 1 to 14. The column on the left represents the symptoms that were present prior to transplant. On the right, the situation after transplant. So you can see that all patients, of course, went to transplant with serious problems. And in general, all of them, almost all of them, fully resolved their clinical features. So this is a very successful series of patients. 14 patients treated with bone marrow transplantation for this disease, all of them being cured. So all of them are alive. No new vascular manifestation, which was another issue. You know, is this hematopoietic intrinsic? Is this hematopoietic extrinsic? In fact, none of the patients experienced new vascular problems. All of them had a full correction of the hematological immunological phenotype, which was the main reason why they went to transplant, and none of them experienced serious infections after transplantation. But there were other problems. Cytopenias were present in 4 patients post-transplant. And cytopenias were a reason why, in fact, there was an idea that perhaps we can do even better and use rituximab prior to transplantation in order to reduce the incidence of cytopenias post-transplant. The other major issue was the reactivation of viruses in the post-transplant course. Again, no serious infection long-term after transplant, but in the immediate post-transplant course, in the first year, basically several patients, actually the majority of them, did experience viral reactivation. And that actually calls for careful monitoring of these patients in a post-transplant setting in terms of properly and promptly identifying viral reactivations and using preemptive therapy whenever this is possible. So it's not a walk in the wood, this transplant in this disease, but it is working as shown in this slide. And then a next question comes, so how should we really transplant these patients? So I showed you a variety of conditioning regimen. I showed you a variety of donor types. So what is the best donor? What is the best conditioning regimen for this disease? These are unanswered questions. And so, again, most patients have been transplanted at a young age. And so is age a factor that has to be considered? Again, this calls for prospective multi-center studies. It's undoubtedly no center will be able to collect enough patients and transplant enough patients to run a clinical trial on its own. It is important to pool all these data together, create a database of these patients that are transplanted, and review the outcome of these patients in a large series, as large as possible, to define, in fact, whether age of transplantation is a risk factor. Is it better to transplant patients at a young age? Do we have a worse outcome if we transplant later? this is not unprecedented because in many immune disorders, if we transplant later in life, we do run into the issue of poorer outcome in terms of both of survival and long-term complications. What is the optimal conditioning regimen? So in theory, you want really to target the myeloid compartment for this disease. And so one could imagine that a myeloablative regimen would be better than a reduced intensity. And perhaps one could say, well, we can go with a myeloablative but reduce toxicity. But I also showed you the reduced intensity conditioning in that experience did work. And so again, this has to be replicated in a larger series. Again, calls for the need of this registry to collect this data and see whether really we need to use a myeloablative regimen, which comes with some higher risk of toxicity, of course. The use of TNF inhibitors has been implied by some people pre-transplant to reduce the burden of inflammation and facilitate engraftment. So that might be a good option, especially if one is going to use a reduced intensity conditioning. And then I already mentioned the issue of rituximab in the pre-transplant, in the part of the conditioning regimen to reduce the burden and the risk of autoimmune cytopenias post-transplant, which can be very severe. In terms of the donor choice, again, excellent results have been obtained, matched sibling donor, unrelated donors. There is very limited experience with haploidentical donors. That's another area that needs to be investigated. We're doing better and better with transplantation from haploidentical donors in many different diseases. So I wouldn't be surprised if the same was true also for DADA2 deficiency and other autoinflammatory diseases, but it has to be proven. And so again, there is a need of this registry. When family members are considered, one has to be very careful and genotype them very, very carefully before considering them as suitable donors, because you don't want to transplant from a genotypically affected individual. And even transplantation from carriers might perhaps come with some higher risk of post-transplant problems. So again, I want to emphasize the need to conduct longitudinal studies, longitudinal observational studies, multi-center studies, have a registry. This is something that will be discussed tomorrow at another roundtable. And also, the long-term outcome of this disease post-transplant needs to be evaluated more carefully. This is a relatively short follow-up that was reported in this blood paper. And we know that, there might be endothelial problems, there might be other cell types that are affected in this disease, and this would not be corrected by a bone marrow transplantation. So what is the long-term outcome of patients with DADA2 that go to transplant remains to be fully assessed. That's an important point to consider. XIAP deficiency, it's another very interesting inflammatory disorder. It's also known as X-linked lymphoproliferative disease type 2. And when this disease was actually discovered, it was discovered as an EBV-driven lymphoproliferatory process leading to HLH. At variants with XLP1, these patients are not prone to lymphoma, but they're very prone to EBV-driven hemophagocytic lymphohistiocytosis. The things, in fact, are much more complicated for this disease, and this is relevant to your interest because it has been shown that the XIAP protein affects actually the ubiquitination process and the release of pro-inflammatory cytokines through the NOD2 pathway in various cell types. That actually results in inhibition of inflammatory cytokines, which may be counterintuitive because this disease comes with inflammation. But the lack of inflammatory cytokines may actually result in GI issues, like seen actually in patients with Crohn's syndrome that are mutated in NOD2. At the same time, more recently, it has been shown that XIAP is also important in a process called necroptosis, which goes through RIPK3. And this is very important for, on the other hand, production of IL-1 beta. So in that situation, you have increased production of IL-1 beta, and that is really the reason why these patients do show significant inflammation. In fact, the phenotype of XIAP deficiency has now become much broader than originally thought. Again, it was identified as a reason for HLH, but as you can see in this slide, it comes from a large number of patients that have been analyzed, 100 of them, 54 presented with HLH, but IBD was present in 26, hypogammaglobulinemia in 16, splenomegaly in 57, and skin abscesses or other inflammatory diseases in 7. So especially GI tract involvement, inflammatory GI tract involvement is very common in XIAP deficiency. So because of the role in XIAP also in preventing apoptosis, because it's an inhibitor of apoptosis, one has to be careful about the toxicity that some chemotherapy regimens may induce, because chemotherapy, of course, induces apoptosis. And so if you're inhibiting apoptosis, you might actually create toxicity to the system, to the organism. And so that might result in an increased rate of adverse events following bone marrow transplantation. So what is the experience with transplant in this disease? Well, the initial results were actually not so good. These are actually the first series. It's a paper that was published by Rebecca Marsh in 2013 from Cincinnati. And what it shows is that a couple of things. Number one, that depending on the type of conditioning regimen you use, if you use a myeloablative conditioning, actually you have very poor survival, 20% survival at 3 years. If you're using a reduced intensity condition, you do better, but survival is only 50%. That's not actually ideal. The other thing that it shows, which is also important, is that the status of the patient at the time of transplantation makes a big difference, because patients who receive reduced intensity conditioning but were in remission at the time of transplantation did significantly better than any of the other combinations. So it's important to take good care of the patients and bring them to remission and then use a reduced intensity conditioning. Based on this data, the protocol for transplanting XIAP deficiency has evolved, and so now everybody would agree that to use a reduced intensity conditioning regimen. And with those data in mind, in fact, a more recent series have shown, although in a limited number of patients, has shown very good survival. All of these patients, all of the survivors, the only patient that didn't survive actually received a myeloablative regimen in this series, but all of the others received reduced intensity conditioning, and they all developed full chimerism. And in all of them, the inflammatory disease significantly improved post-transplantation. So again, we're learning, but we're learning through accumulation of data. And again, this calls one more time for collaboration among centers to pull together their experience. In fact, I mean, there are even more recent data. This is a paper that was published a couple of years ago using an unrelated donor transplant with, again, using this case of a pre-transplant anti-interferon gamma monoclonal antibody to dampen inflammation prior to transplantation and bring the patient in a better status at the time of transplantation. Again, a successful story, and very similar. This patient here received also a haploidentical transplantation, which is something that was not considered before, with alpha, beta, and CD19 depletion. This was a patient actually presented, in fact, with an severe inflammatory manifestation, a very early onset inflammatory bowel disease, was discovered to have XIAP deficiency, was transplanted early in life, and is doing extremely well. So again, we're learning as we go. The very last example I want to discuss is POMP deficiency, because again, as I mentioned, Cecilia Poli, who's here, discovered actually 2 patients with this disease. POMP is important for the assembly, for the formation of the proteasome. It's still unclear exactly whether, well, I mean, in that paper actually it looked like the patients had only POMP deficiency. There is another paper by Raffaella that shows digenic inheritance of POMP deficiency with another gene defect, resulting in a much broader and more severe clinical phenotype. But the difference between POMP and the other Kendall diseases is that these patients don't really develop a significant lipodystrophy, and they are in fact much more immunodeficient than the other Kendall disease patients. And so perhaps transplant applies better to this scenario than to the other Kendall disease. At the same time, though, these patients do have an interferonopathy signature, and so it would be important to see whether transplant really cures this disease. And for what I know, although the data are not published yet, both patients that received transplantation for POMP deficiency at Baylor have now been cured, and they're going home, I understand. They're being discharged in these days. So again, it's a moving target. Even disorders that we were not considering for transplant now are amenable to transplantation. Very last slide is just to make again a point that we are dealing with a whole array of different conditioning regimens. And here on the y-axis, on the y-axis you have the degree of myeloablation, and on the x-axis you have the intensity of immune suppression, because typically conditioning regimens contain both immunosuppressive drugs as well as myeloablative drugs. And you can go from anywhere from no myeloablation, no intensity, or a little bit of immunosuppression and very little myeloablation, to conditioning regimens that are fully myeloablative and fully immunosuppressive, all degrees, all intermediate degrees. These things are evolving. I think it is important to consider the specifics of the disease you're targeting, the clinical status of the patient at the transplantation. One conditioning regimen does not apply to all patients with that disease. You really have to look at individual patients and decide what is best for the interests of that specific patient. But again, it is important to collect data at the international level, share the data, and see eventually what type of conditioning will be more efficacious or less efficacious for given diseases. And I'll stop here, and I'll let Dennis.
Okay, I'm not going to twist my neck around like Gigi and Harry. This ends the scientific part of the session. I don't know if this is working or not. I may be done before I get my slides up, so I won't need this. So I'm from the transplant side. We see the world through a very narrow window. It depends on your disease. It depends on where you are in the course of the disease. It depends on your donor options. And then you think about your disease and the conditioning regimen, and then the last is how you're going to prevent graft versus host disease. So that's our world, and we focus on that. We focus on how are we going to get the graft in, how are we going to prevent graft versus host, how are we going to condition them, and how are we going to prevent graft versus host disease. So I've transplanted primarily GATA2 deficiency and DOC8 deficiency. We've transplanted nearly 100 over the last 10 years with those two diseases. And the type of things that we learned, see, I'll be done before they get my slides up. It won't take long. Several of the things we learned is you try to cool them off as much as possible coming into transplant. If you have active MAC, you don't want to take them to transplant. It's a very inhospitable environment for getting normal stem cells in. So we try to get them in the best shape we can. Then we spend a lot of time trying to figure out which donors we're going to use. The thing that's really opened up the field in the last 7 to 10 years has been the use of haploidentical donors. It used to be anathema, the idea of using a half-matched donor. Now the idea of using a parent or a child as a donor has just opened up. Almost everybody has a donor. And the big breakthrough in that, I don't think I need my slides. Anyway, the big breakthrough, the big advance in that is the use of post-transplant Cytoxan. So you give the donor stem cells on day 0, and then on days +3 and +4, you give a high dose of cyclophosphamide. And it turns out all the lymphocytes, the alloreactive lymphocytes, go into cycle, and they're exquisitely sensitive to a cell cycle agent like Cytoxan. So that's really cut the graft versus host disease, acute graft versus host disease, from 40% to 10% across the board, including haplos. Chronic graft versus host disease used to be 40%, it's 10%. So that's opened up the whole field. So anyway, those are the big things I think I want to just mention. Focus on your disease. In the case of GATA2, we learned that if you get them early, it's easy to get a graft in. They got an empty marrow. They're like aplastic anemia. If you get them later and they have a clone headed towards AML, you have to use a high-dose regimen or you're going to get relapse. So it's not only the disease, it's the course of the disease. And as far as the conditioning regimen, we've actually found using a busulfan-based regimen, we have almost no regimen-related mortality. Nobody dies in the first 100 days of transplant. So by targeting that level, you can get right at the level where it's not quite myeloablative, right at the border, and you have no early toxicity. So those are I think those are the big kind of take-home points. Haplo's. Somebody asked you, what did that guy say? He had no slides. He said, get them in the best shape you can coming into transplant. Haplo's the big deal, and I think those are the big things. All right, that's my talk. Thank you.
Well, thank you so much for staying late for us. Is there any question so far? Okay, I am going to take another 10 minutes or so before the end of the day. Let me see. And I'm going to change the optics a little bit. You have heard about hematopoietic stem cell transplant, and I'll be telling you about mesenchymal stem cell transplant. If I can have the first slide. It's 18D. Is there any questions so far? Yes. Yes. Okay. So mesenchymal stem cells, I'm just going to give you a little background on this very briefly. International Society for Cellular Therapy defined mesenchymal stem cells as adherent cells, which are able to self-renew and differentiate into multiple tissues in vivo and in vitro, and express surface phenotype of CD90, 105, and 73. These are CD34 and 45 negative cells. And they are dispersed throughout the tissues as pericytes, and including they are located very close proximity to hematopoietic stem cells in bone marrow sinusoidals, and modulate through evolutionarily highly conserved mechanisms to provide tropism, immunomodulation, and angiogenesis. And they determine health. They are very important or vital for health and vitality, as the numbers of mesenchymal cells decrease along with aging throughout life. So these cells are immunomodulatory, and they are immunomodulatory by paracrine soluble factors mostly, as well as cell-to-cell contact. And they inhibit activation as well as proliferation of innate and specific immune system cells, as well as they change the balance in the regulatory components, cellular components. So they're very potent, and they have plasticity, and upon priming, they can change their expression profiles greatly. One of the main soluble factor that is involved in the immunomodulation in don't-limiting deoxygenase, for instance, is increased greatly in the presence of interferon. And if you add in IL-17 into the mixture, then you have increased nitric oxide synthetase produced by these cells. So they change their profile, and they show adaptability to the microenvironment. So in vitro, this is one of our data that they are very potent in terms of their inhibition of the T cells in the presence of mitogen or anti-CD3 treatment or activation. In the presence of MSC, the proliferation is nil compared to in the absence of MSC. And there's a dose response to see that effect. And in vivo, from the studies that on autoimmune diseases, the pattern is emerging that there's increased IL-10, increased T regulatory cells, and decreased Th17 cells in treated populations who respond well. So I would like to suggest there are 3 potential indications for MSC treatment. And for severe and persistent inflammation among autoinflammatory and immune dysregulatory patients. The second one, which is probably the most important one, is an adjunct therapy to hematopoietic stem cells, both myeloablative and non-myeloablative or reduced intensity conditioning. And also, there's the last one is establishing donor chimerism as a surrogate of gene therapy, introducing healthy gene. So when we look at the hematopoietic stem cell transplant, If the engraftment is poor, then that becomes a problem, and that may come with poor immunocompetence. On the other hand, if the engraftment is detrimental, then GVHD is the major problem in these patients. So hematopoietic stem cells the mesenchymal stem cells can be helpful on both ends. This is the data on so far what we have on severe autoinflammatory diseases. It's done only on systemic juvenile arthritis for mesenchymal stem cell treatment. There are 2 studies done. One is from China, and the other one is by Dr. Wolfrat, Netherlands. And both of them, actually, the indication of this is severe arthritis. The Wang cohort had 10 patients, 6 with systemic arthritis, and 6 out of 6 in Netherlands is systemic arthritis, but the patients were treated mostly for polyarticular arthritis, and only a minority had systemic features. So these were mostly chronic arthritis patients, and they were on systemic medications. They got unrelated mesenchymal stem cell treatment with repeat infusions, and follow-up was up to 2 years. And both studies showed safety of the treatment, and all patients improved for arthritis. Oops, let me go back. And in Wang's study, they did look at the acute phase reactants and the disease biomarkers that was with improvement, decreased WBC count and SED rate, CRP, and inflammatory cytokines. So this is for the data that I'd like to share with you for MSC treatment, for acute GVHD treatment. The first one is LeBanc study published in 2008. This is the landmark study, which opened the whole field of using mesenchymal stem cells for graft versus host disease. In this study, these patients had very severe steroid unresponsive GVHD, and they received MSCs. Some of them received repeat MSCs, and some of these patients, a total of 55 patients, there were 17 children, and they responded actually to treatment better than adults. And 5-year survival was much better than the data without presence of MSC treatment. So almost half of them, there was at least 2 times improved survival among patients treated with MSC compared to non-treated. And this study was followed up by a trial using MSC for GVHD among children only. And in this study in 2011, again, the treatment provided improved survival compared to non-responders. And in this study, initial 2 was on myeloablative regimens. This is non-myeloablative regimen, and they used completely unrelated, unmatched bone marrow, hematopoietic cells, which of course brings big risk for GVHD. And in this patient's MSC, again, improved the survival and progress-free survival, as well as survival, and 1 year was much better among treated patients compared to historical controls. This is the patient that we treated in 2000 with non-myeloablative bone marrow transplant with crude, non-fractionated bone marrow sample. The child got fludarabine, Cytoxan, and low-dose total body radiation, low dose. And she also had mesenchymal stem cells to with the hope of increased engraftment of the hematopoietic cells, and this was followed by daily treatment with steroid cells and cyclosporin for up to 9 months. This child was 12 years old with lung vasculitis overlap syndrome, and this is her lung biopsy. And in long-term follow-up, she did very well. She's in full remission, cure. And this protocol, again, was repeated by Dr. Cahill. This is his cohort on 5 patients. The last one was my patient here on infantile hypophosphatemia and Hunter syndrome and hyper-IgD. In this study, the similar protocol, the mesenchymal cells were given as bone chip implanted in the peritoneal cavity, as well as the ex vivo expanded mesenchymal stem cells IV. And you can see that even some of the patients, the initial 4, didn't have much of blood chimerism or engraftment of the hematopoietic stem cells. They did have clinical improvement, such as seen here with the improved bone density and the structure on the Hunter syndrome. So the similar protocol was applied then in mice. This is BXSB lupus mice that we did. And after total body radiation with different levels, either non-myeloablative or this is 550 for mouse, is non-myeloablative, 950 is lethal irradiation. We were able to show that in total match H2 to H2 transplant of the mesenchymal stem cells did have engraftment. This is spleen. There's, of course, no hematopoietic cells, so spleen is negative. Kidney, we did see some engrafted cells. And in the unfractionated bone marrow, you do see engraftment because bone marrow, when it's unfractionated, you do have mesenchymal stem cells along with hematopoietic stem cells. So the engraftment, you can see the spleen engraftment was much higher as you expected for lymphocytic involvement or hematopoietic cells. But you can see some somatic cell engraftment in those crude bone marrow samples. And the engraftment pattern can be different, depends on how you give these cells. This is the similar mice that got low-dose radiation in the liver. If we give IV, it usually was in the sinusoidal engraftment versus if the cells were given in IP, it was mostly periportal engraftment. And similar studies have been reported, but you do have some sort of conditioning to mostly radiation. Actually, radiation works very well for some reason for engraftment. These studies are difficult to do in humans, but it's in mice, in animals. So one of the reasons that engraftment is, it takes a lot of interest is the post-myocardial infarct. There are studies giving mesenchymal cells to improve the myocardial function. And in those models, this is again in murine models, they do inject the mesenchymal cells directly. These are single cell suspensions. And without any conditioning, you can see some cells remaining, but these cells are gone by the end of first week, and the remnants of these cells are usually found in the macrophages. So without conditioning, it's very difficult to engraft. So the challenges with the mesenchymal stem cell treatment is we really don't have any control upon injection of these cells in vivo, again, and the homing is remaining a concern. The local injection has been used and it's been shown in different models. It's very effective, including us. We tried it in lupus kidneys that we showed a good trend. And engraftment is challenging. Priming mesenchymal cells, for instance, exposing them to interferon works better for GVHD models in animals. Using exosomes is a very big interest, cell-free products of mesenchymal cells, because these cells work mostly with the soluble factors. And long-term concerns always is malignancy. Ectopic transformation is always a concern, but so far that has been a minor thing in the literature, although whether or not every patient is reported in the literature is questionable, but so far that hasn't been coming as a big concern. So we know that the cells, if you give full match, especially in the presence of a scaffold, you can have these cells remain in the recipient longer compared to non-match or non-scaffold conditions. And the last data is the exosome content can be inhibitory on inflammasome, NLRP. This was done in, This was done in kidney epithelial cell model. When you expose these cells, you can induce apoptosis. And in the presence of mesenchymal cells, you prevent apoptosis. And this shows the NLRP3 activation. When you induce apoptosis with these cells, in the presence of that, it's reduced, NLRP activation reduced. And if you give hypoxic MSC, which induces the exosome release, then you really can inhibit the NLRP activation greatly. And this shows the microRNA cargo in the exosomes released by the mesenchymal cells in the absence or presence of hypoxia. So this brings us the protocol development as discussed. And to me, the immune modulation and somatic tissue is a different important arm in the protocol development. And as you increase the immune modulation, then when you give hematopoietic stem cells, then you absolutely, of course, accomplish immune modulation. If you give hematopoietic plus mesenchymal stem cells, you can provide immune modulation as well as somatic tissue engraftment and chimerism. If you give MSC alone, there has been immune modulation, as I showed you, with soluble factors mostly, as well as cell-to-cell contact mechanisms, and it is still in the works how we can engraft MSC and provide donor chimerism. So in summary, MSC-based treatment is promising, and it is FDA approved for children for GVHD in Canada. Tailored protocols can provide immune modulation and preserved homeostasis in high-risk patients. And this is accomplished by soluble factors for tropism and immune modulation, which is usually short-term. In most models, this requires repeat MSC injections or engraftment for tolerance and gene delivery, which can provide long-term solutions. Thank you. Any questions we can answer?
So I'll just make a comment. One of the reasons why I was scheduled to talk after Gigi and Dennis is that a very key and important point is that if bone marrow transplant will cure a disease, then we should be able to develop gene therapy for that disease. Contrary-wise, if you can't fix the disease with bone marrow transplant, then probably targeting gene therapy to the hematopoietic cells is not going to work, and you need another approach. That's a key element here in how this discussion of transplant and gene therapy, connects together. we're here late.
Thank you so very much. This concludes our day. Appreciate it.